Welcome to the Australian Dental Council Explainer podcast. Today, we outline the strict ADC examination pathway and examine the precise clinical protocols for managing anaphylaxis, chronic kidney disease, and medically compromised patients. Earning registration in Australia requires proving clinical competence within a high-stakes clinical assessment environment. The ADC pathway follows a set sequence: an initial assessment of credentials, followed by a written examination, and concluding with a practical examination. The written examination format has been redesigned to remove all standalone multiple-choice questions. The assessment now uses a scenario-based cluster format. Candidates must answer 5 interconnected questions that evolve alongside a single clinical vignette. Using the modified Angoff method, the ADC no longer grades candidates on a curve. Instead, they are measured strictly against the benchmark of a minimally competent new graduate. Success in this assessment depends on the application of safe clinical logic to unfolding patient scenarios, moving past the simple recall of theoretical facts. Eligibility for the exam requires a 4-year full-time university dental degree and unrestricted registration in your home country. Updates from March 2025 also mandate specific English proficiency standards and the creation of an ADC Connect account. Completing the initial assessment by the deadline is a prerequisite, but it does not automatically guarantee a seat in the examination session. The written exam is an intensive 2-day process consisting of 280 questions delivered across 4 separate 2-hour blocks. Every question is mapped to an official blueprint of domains and disciplines to ensure the test provides a balanced clinical sample. The blueprint assigns specific weightings to subdisciplines. Pharmacology represents 10% of the total content, while implants account for 4%. Candidates are advised to map their knowledge gaps specifically to the blueprint, rather than attempting to study all available dental literature. The ADC does not endorse or recommend any proprietary third-party preparation courses, as these are developed without official council input. Passing the exam requires strategic adherence to the official syllabus parameters and a focused study plan. Anaphylaxis represents the highest priority clinical emergency evaluated within the ADC framework. This ABCDE diagram provides the clinical framework for diagnosing rapid patient deterioration in an Australian dental setting. A typical presentation involves an acute illness developing over minutes, characterized by changes to the skin or mucosal tissues. This diagnosis requires accompanying systemic indicators, such as respiratory compromise, a drop in blood pressure, or severe gastrointestinal distress. However, if acute hypotension or bronchospasm occurs immediately after exposure to a known allergen, it is diagnosed as anaphylaxis. You must reach this diagnosis even if the patient shows no typical skin features, like a rash or swelling. Fatality can occur with extreme speed. As this data shows, injected drugs cause a significantly faster progression to cardiac arrest than food-based triggers. Delaying intervention to wait for a rash in a hypotensive patient is a critical failure of clinical judgment. Immediate management requires you to stop the procedure, remove the suspected trigger, clear the airway, and call for emergency assistance. The patient must be laid flat immediately. Sitting or standing during anaphylaxis can be fatal. Gravity causes blood to pool in the lower extremities, leading to a sudden, irreversible cardiac arrest. The mandated treatment protocol is the administration of intramuscular adrenaline. Adrenaline must be delivered via an intramuscular injection into the outer mid-thigh using a strict 90-degree angle. The standard adult dose is 500 micrograms, while children are dosed at 0.01 milligrams per kilogram of body weight. If the patient does not respond, the exact adrenaline dose should be repeated at 5-minute intervals. Supplementary care includes high-flow oxygen at 15 liters per minute and a 000 call to emergency services, specifically identifying the case as anaphylaxis. Patients must be transferred to a hospital for at least 4 hours of observation to monitor for a secondary biphasic reaction. Always defer to your local emergency protocols and exercise your own clinical judgment when administering emergency care. Survival in these scenarios depends entirely on algorithmic precision and the rapid execution of standard protocols. Managing systemic risk begins with an exhaustive health history review during the initial consultation. Clinicians must identify past allergic reactions to latex, NSAIDs, or antibiotics and ensure high-risk patients utilize Medic Alert IDs. Chronic kidney disease serves as a primary example of the systemic complexity evaluated in ADC examinations. CKD is identified by an eGFR falling below 60 or a persistent positive result on an albumin-creatinine ratio test. These markers mandate that all drug dosages be recalculated based on the patient's specific renal clearance. Prescribing over-the-counter NSAIDs to a patient with impaired renal function can lead to severe systemic complications. The triple whammy interaction, combining an ACE inhibitor, a diuretic, and an NSAID, causes a rapid decline into acute kidney injury. Evaluating renal clearance is a necessary step before prescribing routine dental medications. Metabolic factors further complicate renal function. Obesity, or a BMI over 30, is a major risk multiplier for kidney disease. Clinicians must use body surface area adjustments when calculating eGFR for obese patients to ensure dosage accuracy. There is also a direct connection between obesity and obstructive sleep apnea, which can lead to hypertension that is difficult to manage during dental procedures. Severe liver disease also impacts these assessments, potentially distorting eGFR results and requiring caution with calcium channel blockers. Precise dental therapeutic steps for managing obesity and liver failure are limited in current source texts, marking a clear boundary in the existing evidence. Please subscribe to the channel for more breakdowns. For detailed protocol reviews, reference the official ADC handbooks, the ACEA guidelines, and the Chronic Conditions Manual. Earning the status of a competent Australian graduate involves managing the patient's systemic health as the central component of dental care.